Welcome to Fluorescene.
Hello, and welcome to Fluorescene Show number 17. I'm your host, Dr. Alan Glazier. Please don't forget to subscribe by hitting the red button right down there to receive shows and segment updates and qualify for contests and giveaways in the near future. Now this week, as usual, we learn there's never a dull moment in ODs on Facebook. A doc posts their patient is upset that her vision is blurry after taking her glasses off and wanted to know what other things docs have heard from patients that make you go, Well, one doc had an angry father whose son couldn't see out of the glasses he got at Costco, blaming the doc for writing the wrong RX, of course. It never happens to me, though. What really happened is the father gave Costco his wife's RX, not the son's. Shocking. These patients, they're quick to get angry. They don't unanger easily, right? Then a doc brought up the phenomena of patients who report a big change in their vision, and nothing in the history is adding up. So what do? You keep pushing them for more history. They finally report that it only happens when they take their glasses off. Of course. This is the worst, though, when it happens at the end of the exam. And this is why we drink. Next, there was a doc who told the patient she was going to look at the back of her eye. What does the patient ask? Do I need to bend over? I'm not going to do anything with that one. This is a family show. And when you show them their old RX compared to their very different new RX at the end of the exam, and their response is, wow, did my prescription change? Internal voice, really? You're an idiot, and clearly the gene pool is shallow near you. Now, this was an interesting one. A doc shared the time a patient's car caught fire in the parking lot. Wait, that's not the interesting thing. What was interesting was the patient chose to continue with the eye exam while police and firefighters were putting out the fire. Yeah, that's interesting. I'm thinking he either set the fire himself for God knows what reason, or didn't set the fire, but in the epitome of passive-aggressive behavior figured, well, too late to do anything now, or made the value judgment that a missed exam fee is higher than the value of the car, and mentally wrote the car off. Who knows? You know, I long thought that I'd love to publish a coffee table book of stupid things people write on entrance forms that are posted in ODs on Facebook. A doc posts this entrance form and writes, guys, I can tell I'm going to need help on this one. Hope the patient's okay. I always wondered why people automatically think astigmatism is such a bad thing, even a disease. Maybe it's because it has the phrase stigma in it. Or it just plain sounds like a word that means something awful, but it really isn't that awful. Like borborygmus or masticate. One doc was told the other day, my grandma died from astigmatism. So sad. What a painful way to go. I bet her epitaph read, she always lived against the rule. And then there are people who are over -5 with 3/4 of a diopter of sil who put in their reason for visit, you guessed it, astigmatism. When you tell people, well, actually everyone has a little astigmatism, they actually look upset, like they're not special anymore, or maybe because they feel a doctor in the past lied to them. Well, at least they don't have the dreaded double astigmatism, for real. A doc posts this and says, got a live one. Now, here we go with microchips and things again. First question is, well, can you? There's so many ways you could mess with these people, like telling them, yes, we're seeing them all the time now that people are getting vaccinated. Or saying, yes, it's $5,000 out of pocket for the experimental chip, or I can render your chip inactive with this handheld light for $5,000. Then there's always the opportunity to refer this person to your least favorite ophthalmologist. Now, a doc posts this pic and asks the community what their thoughts are. The consensus was fundus albipunctatus. Just another beautiful clinical image that I wanted to make sure you didn't miss this week. To find other beautiful clinical images, compelling photos, or scans in the community, just use the small magnifying glass search tool there and type in the hashtag TFT, and it turns the content in the community into only posts with compelling clinical images. A doc wants to know if it's just become acceptable to show up 5 to 10 minutes late to doctor appointments. As if that isn't bad enough, there are the patients who show up late and ask to go to the bathroom after they're put in the exam lane, and you kind of mull around, popping your head in and out every few minutes to see if they're back in the chair, that is. If they acknowledge they were late, and they were very late, you can always ask them, what part of the exam should I leave out? Especially annoying when they get a reminder the day before and a half hour before, and yes, are still late. And guaranteed 50% of people who run late were delayed by a barista because they all come in with a full grande latte. Pandemic is either making people slower, ruder, or crazier. The winning comment was, all exam slots are created equal. All patients are created differently. If you are more than 10 minutes late, you will be rescheduled. Well, that's it for this week in ODs on Facebook. We got a great show for you today. It's the ODs on Facebook Fluorescene Nutrition Edition, where we interview Dr. Julie Poteet and Dr. Pinakan Davey of the Ocular Nutrition and Wellness Society. Dr. Poteet and Dr. Davey provide interesting insight into the latest information on ocular nutrition, and we welcome Dr. Paul Chous, a preeminent expert on diabetes, who discusses his career and discusses the latest science and clinical information on caring for diabetic patients. Dr. Stephanie Wu is here with her next segment of Wu University, where she provides tips for those interested in building a specialty contact lens practice and more. So sit back, pour yourself something, as long as it's not fluorescene on your patient's white shirt, and enjoy this week's show. Today, we welcome Dr. Julie Poteet, President of the Ocular Wellness and Nutrition Society, and Dr. Pinakan Davey, Vice President of SAME. Dr. Poteet received her Bachelor of Science from the University of Georgia, her Doctor of Optometry degree from the New England College of Optometry, go NECO, and a Master's of Science in Human Nutrition and Functional Medicine at the University of Western States. She completed residency at the Brockton and West Roxbury VA Medical Centers in Massachusetts before returning to Georgia. Dr. Poteet works in private practice in the Ackworth area now. Dr. Poteet is an active member of the American Optometric Association and the Georgia Optometric Association. Dr. Davey attended the Elite School of Optometry in Chennai, India, completed a PhD at Anglia Ruskin University in Cambridge, England, and received his Doctor of Optometry from the Southern College of Optometry. He currently serves as a tenured full professor at Western University of Health Sciences. Dr. Davey's awards include the Excellence in Optometric Education Award 2015, awarded by the California Optometric Association, the Provost's Distinguished Scholar Award at Western University, and the Young Optometrist of the Year Award by the California Optometric Association in 2017. His major research is focused on retinal physiology and glaucoma, particularly on improving visual function in disease states. He's authored over 75 international publications and has given over 300 conference and invited presentations, both nationally and internationally. His research work is funded in past and present by the National Institute of Health and industry-sponsored FDA trials. I should note that this interview ran into some bandwidth issues that cut off the video for approximately the first half of the interview. Video resumes at about 17 minutes into the interview. So welcome, Dr. Poteet and Dr. Davey. I really look forward to this interview.
Hi, Alan. Thank you for having us.
My pleasure.
Hi, Alan. Thank you for having us.
Both there. Good. You never know how the technology is going to go. We had a few hiccups there in the beginning, but hopefully the viewers won't even know about that, and I'll cut that out. So tell us, let's talk today. I want to talk a lot about the Ocular Wellness and Nutrition Society. Just tell us about the history of the society to start with, and for our viewers who may not know about it.
I'll start with that. So our society is the society for ODs, MDs, PhDs who have an interest in nutrition. We, Dr. Jeff Anshell started our society, and then Stuart Richer, he was our president emeritus, took it over from there. So our board is composed of PhDs, MDs, ODs, with an interest in research and education in ocular nutrition. So, Pinakan, I'm going to let you jump in here if you want to give some more info.
Right. So, Alan, as Julie was mentioning, it is primarily for an interested group that wants to believe in wellness and nutrition of the eye, body, and the brain, etc. The eye, and it's for optometrists, it's so obvious, right? The eye is just an extension of the brain, and we understand that. So what's good for the body is going to be good for the eye and the brain. And given that there is so much information, there is so much misinformation on this area, being part of a society like this certainly filters out the misinformation and allows you a peer-to-peer candid discussion on the topics that's very important to us and our patients.
So starting with Dr. Davey, so tell us about something that is controversial, something that we may not know about nutrition and what we should or shouldn't be doing now.
Okay, so I will start on this, and perhaps Dr. Poteet will jump in as well. For example, every few years we get something like information that says vitamins absolutely work or do this for your body, etc. And every few years we get some research saying vitamins absolutely do nothing for your body, etc. Why such two pieces of information that are so polar opposites? Okay, for example, something like the DREAM study, which looked at omega-3s. The controversy is the placebo group was very much not a true placebo, but could have had its effects on its own. But things like this are very important to optometrists and to their patients, and to understand why you could believe it or not believe it would be certain controversies that come to my mind.
Yeah, those are definitely controversies. Dr. Poteet, do you have anything to add to that?
I do want to add that, for ODs not to consider nutrition as important, it is not in line with what's going on right now in research overall. May of 2020, the head of the National Institute of Health, Dr. Francis Collins, introduced a 10-year study in nutrition research. He was head of the Human Genome Project, which was a 15-year project, which, when completed, we thought, oh my goodness, we're going to have all the answers to so much in science. And what we learned is that genes aren't destiny. It's our environment that kind of dictates how our genes are expressed. Therefore, our microbiome and our food are so incredibly important. 2008, Dr. Collins headed up the Human Microbiome Project, and now he's heading up the Human Nutrition Initiative, which is a 10-year initiative in nutrition research. So if you look at endocrinology, rheumatology, cardiology, all these different fields that impact the eyes, you're going to see so much more nutrition research coming down the pipeline, and so much of it's going to be personalized nutrition. And so every patient, we see in the clinic has got something going on with their eyes or their bodies that nutrition can be impactful. And it's up to us, to practice to our full scope. And so we as a society want to, bring our profession more into thinking from a nutritional standpoint. Our newest fellow, Dr. Danny Walker, just did a beautiful paper on nutritional considerations for mild traumatic brain injury. And, TBIs are so common. They have, 40% of the sensory input to the brain is the visual system. And inflammation from a TBI in the brain can affect the eyes in so many different ways. And his paper was wonderful. He taught me a lot, like DHA from omega-3s help mitigate the inflammation in the brain post-traumatic brain injury. Exercise combined with DHA helps promote brain-derived neurotrophic factor, which is a hormone, it's like throwing lighter fluid on a fire for neurons and helping them kind of make those connections. So there's so much we're learning and so much we can do to add to our patients' lives. And that's what we as a society are here to promote.
I love that quote you said, that genes aren't destiny. And
No.
I think what that implies is that the nurture nature side of things, maybe even some optometrists have heard about epigenetics and how genes play a role and how nutrition influences that. Is that kind of what you're talking about when you say genes aren't destiny?
That's exactly what I'm talking about. And if you look at the research now, there's so much on, say, the Mediterranean diet and prevention of AMD. In fact, Emily Chou, who headed up the ARID study, is just quoted as saying, post a study she looked at where Mediterranean diet reduced the risk of AMD, that it's time to take quitting a poor diet as seriously as quitting smoking. And we now have the research to substantiate ways that we can not just mitigate the course of a disease, but help prevent it. And this is powerful. So
that is powerful. Dr. Davey, on the same topic, are you aware or could you make me aware of any peer-reviewed, perhaps longitudinal studies on epigenetics and how they impact the eye? When I looked into this a few years ago, I failed to find, it was a great idea, a great suggestion, and I'm sure there were basis in reality for a lot of the claims, but I failed to find the data. Where are we now with that?
So think about it this way. We don't directly actually see studies that say we're looking at the epigenetics and the genetic markers that are necessarily going to change. But the fact that the ARID study, in fact, showed that you could prevent or change the progression of a disease despite having risk factors for a particular disease, or could modify what percentage would convert or not, I would actually justify that to some extent because of epigenetics and changes that you can alter or the things that you can do. So I guess a more general precursor to epigenetics would be to understand risk factors and say, what are the modifiable risk factors and what are the non-modifiable risk factors, and looking at it very critically and saying, are the non-modifiable risk factors truly non-modifiable, or is there anything that you can actually get some help from alteration in your day-to-day activity? And that's where the epigenetics come into play. So even though we may not have direct studies, longitudinal studies looking at your genes and saying the end tips of your genes and saying, did it change, did it not? Maybe the length goes longer, shorter. Those are cool. But I think the clinical trials are the evidence that changes can be done. It doesn't have to be a fixed destiny.
So Dr. Poteet, I have a question. This is something in clinic that I always encounter and something that I believe, and I had some data and studies to back it up. Vitamin versus food. When you're making recommendations for patients who have a family history of macular degeneration but have no disease state themselves at this point, and they ask you, should I take one of these supplements? How do you answer that question? And where does food versus vitamins and the unknowns of how much we absorb from vitamins come into that conversation?
It's always best to get all your nutrients from food, but our food quality is poor. And sometimes you just can't get enough. Dr. Richer and another MD in our board just published a study. It was 9 years in the making that looked at offspring in AMD patients, offspring without evidence of clinical disease. It was the early biomarkers of age-related macular disease study. And what it looked at is macular foveal pigment density. The one magnanimous factor was the percent of omega-3 red blood cell index, which is how much omega-3 is in their diet. That was a mitigating factor that helped determine who was going to go on to develop disease. And so my patients' offsprings of AMD, per the ARIDS trials, are not in the recommended category of recommending an ARIDS supplement. But I recommend omega-3s to all those offsprings because we just don't get enough in our diet, our diet today. And I always question every patient about diet. The NIH's nutrition research is heavily invested into personalized nutrition. So I don't think you can make just one blanket statement for any patient. I believe in always talking to them about what foods they eat. And I always recommend omega-3s to the offsprings without evidence of clinical disease yet. So.
And it also sounded like you were concerned heavily about the quality of the foods we eat. Can you tell us a little bit about that?
Well, you know, our diets, if you look at our diets and what we eat, our food in industrialized nations has changed tremendously in the past 20, 30 years. Our rates of autoimmunity are skyrocketing. If you look at the microbiome, which I'm heavily invested in microbiome research, I think we're just at the tip of the iceberg. But if you look at the diversity in our microbiome, and our microbiome helps dictate inflammation in the rest of our body. So if you look at our diversity, and a more diverse microbiome is associated with less autoimmunity, less inflammation. We in the industrialized countries have less diversity. If you compare it to Africa, people in Africa who eat complex carbohydrates and whose diets are not heavy on processed foods, we just are at a point in our development where we eat poorly, and so we cannot always get all of our nutrients from diet. You know, if you look at the ARIDS populations, ARIDS-2 population, they were a well-nourished, well-educated population. And that's not what we are always seeing in clinic. In fact, we see the opposite most of the time. And so, you know, I do recommend vitamins. I always recommend omega-3s for so many reasons. A study just came out today that I was reading about omega-3 levels and risk of type 2 diabetes. And which supported the use of omega-3s. So I'm a huge proponent, and I think it's substantiated in the research. And, you know, I like to tell my patients, you know, when you take omega-3s, for dry eyes, for example, it's providing collateral benefits. You're not just working on the ocular surface like a cyclosporine or, you know, an artificial tear. So there are collateral benefits to the nutrients. We're not just taking them for our eyes.
Excellent. Yeah, I agree. I've always enjoyed recommending omega-3s because I knew I was doing good for people's hearts as well. So that's just a good example of that. Dr. Davey,
may I actually jump in on that same question?
Yeah, please.
And I'll actually keep it very brief.
No need.
They're called nutritional supplement for a reason. They are a supplement to your nutrition. They are never the main course, right? So if you asked your patient, what did you eat yesterday? Some people might remember it. What did you eat day before yesterday? Maybe 10%, 20% people remember it. 3 days ago, and it goes down and down and down. And what happens is, in our busy lifestyle, we try our best to get our best diets, but we just don't get it. And you can actually argue, is the food available? The answer is yes, it's always available, depending on what amount of money and time you have available to invest. And the money and the time are the rate limiting factors, so as to speak, not necessarily that the best food is available or not. Although one could argue that, you know, either organic versus non-organic and the nutrient contents can be variable, etc. They are okay. Over long term, if you take fruits and veggies and you continue taking them, even though the exact amount in the best quality versus average quality is not the same, you would get sufficient amount of it. But the problem lies with the rate limiting factors, which is time and money. And that is always the problem. And so nutritional supplements can give you a very much a systematic way of augmenting your diet. And it is so difficult to disprove or prove that a nutritional supplement helps over the course of 80 years, right? Meaning if you start taking it early in life, and the average lifespan these days are in the mid 80s, you know, it's hard to justify what really helped in that 80 years. But it's probably a combination of diet and the supplements and the other protective things like wearing the right kind of sunglasses, not abusing your body, those things.
Excellent. So this is really incredible information, and I think that people who look into, who want this kind of information will find it if they consider joining the Ocular Wellness and Nutrition Society, and I want to talk more about that for sure. So that's really interesting. In being a practicing optometrist and being and practicing nutrition and having things to offer my patients, I would say that 95% of the products that I'm aware of include products that are offered to help the macula in some way or prevent or the continued worsening of macular degeneration, and omega-3s, which generally are used for the eye for dry eye. That's 95 to 99% of the products I'm aware of. Can you tell us, as optometrists, what else we may want to think about when it comes to offering eye nutrition to our patients?
Absolutely. So, Alan, the reason that majority of the products that most people are aware of is because of the AREDS trial, right? So the big AREDS trial showed such an impact on preventing progression that's what we can think of. But you have numerous other nutritional supplements, and one has to ask, is it chronic disease? And the answer is yes, there's probably a nutritional role to play. For example, diabetic retinopathy or diabetes is such an endemic disease, and you have all kinds of oxidative damage that occur in patients with AMD and in the retina can also occur in diabetic individuals and the diabetic patients. So there are diabetic nutrition supplements that are available. There is a dry eye supplements that you mentioned that are actually available. And one very dear to me, and the reason it's very dear to me is because we all have gone through 2020 of Zoom life. We are always on Zoom, talking to each other on Zoom. We were already on our screens for about 10 to 12 hours a day, and now we have gotten even worse with the Zoom technology and the Zoom life. And so screen time is a real big problem to your body. You see changes in your physiology, and you see changes in your eye. And so one has to think, if there are appropriate screen supplements or screen time supplements, I take them. I actually give them to my kids as well, because they're on Zoom. Their schooling's on actually computer fully these days. And so those things help a lot. So there are numerous supplements. And of course, the most dear to my heart is actually, to some extent, is glaucoma. And there is growing evidence that nutrition will have a role to play. So you probably have supplements in all these categories, and as doctors, we'll have to do our homework to make sure that we like the data or research behind that supplement to be able to feel comfortable to prescribe them to ourselves and our patients.
And that's one of the beautiful things about OWNS, is because everything we talk about is backed by science and backed by research. And Pinakan, I want to piggyback on something you said. So many of these nutrients that we take for eye care, for just systemic wellness, have collateral benefits. Anything you do that's healthy for the macula is healthy for the vascular system, the heart. Omega-3s work on all levels. One of my favorite areas where I use omega-3s in clinical practice is in my pediatric population. DHA is a huge driver of something called brain-derived neurotrophic factor, which is a hormone in the brain that makes those neurons kind of on fire for learning. And so, research has shown that when you supplement with DHA, it actually helps with learning and memory. And so my amblyopes, my kids, I supplement them with DHA. Another area that's growing in eye care, and what we know from one of our research by actually one of our board members, it shows that lutein and zeaxanthin not only deposit in the back of the eye, but they deposit in the visual processing areas of the brain. So one of my favorite things to do for my pediatric population is give them lutein and DHA, because what I'm doing is I'm helping to facilitate learning and processing. Research on dyslexia, for example, has shown those kids have low levels of DHA in their brain. Research on ADHD shows that supplementing DHA helps not with the hyperactivity component, but with the focusing component. So anything I can do, when I look at a patient, I look at the whole patient, and anything that I can do to modify and to help them in areas in parts of their systemic biochemistry that may be lacking, or anything I can do to augment their function, I do it. I prescribe it, and I think the pediatric population is a huge It's kind of something that we're all not thinking about, but it's an untapped market, in my opinion.
So, Alan, let me just tell one more thing on that area.
Sure, please.
And now that we've opened the box, we need to actually fully open it and explain it. So, what is the difference between a child's brain and an adult brain? The child brain is still developing. The adult brain is developed, or although if you ask our spouses, they'll say our brain has never developed. If you ask my wife, she's probably going to tell, nah, he hasn't matured, the brain's not developed. But jokes apart, the reality is that our brain is developing. And then from your youth, you are getting older. None of us want to confess to that. And our brain composition is changing there too. So let's talk about it in three parts, right? So children have a developing brain. They require more processing, and they are undergoing changes. And there is so much changes going that requires certain carotenoids, lutein, zeaxanthin, to be present in much greater quantities than adult brain. So children's brain have a different composition than adult brain of carotenoids. Now we might think, wait a minute, I thought carotenoids actually prevent blue light, and you have a big skull. It's not going through the blue light's not going through. So what are carotenoids doing there? Well, actually, carotenoids do a lot more than just preventing blue light and preventing AMD damage. They actually allow for a faster processing speed. And the child's brain is developing, so it requires faster processing speed. This one study done by Naiman Khan and colleagues in Chicago, Sasha Barnett was the first author of it. What they did was beautiful and elegant. They looked at children, and they looked at the macular pigment optical density scores, which is basically the yellow spot that we are all so used to seeing in our ophthalmoscopic findings, right? They measured the pigment density, and they then balanced the group by statistically, by calculating their IQ and saying, if you balance the group for statistically by IQ, the people that had greater macular pigment optical density, they actually had, even after accounting for IQ, better math scores, better learning scores. What is the relation between this foveal spot and your brain, you may ask? And the reality is, we know this, but do we really know this? We all assume, and we say eye is just an extension of the brain. Well, what gets deposited in the retina also gets deposited in the brain, and in fact, the correlation is spectacular. About 80 to 85% correlation between your eye levels of carotenoids and your occipital cortex and your brain levels of carotenoids. So as optometrists, we can actually tell if a person has sufficient levels of carotenoids in their brain by just measuring their eye pigment level. Now, the third point, which I did say I was going to go to parts of three, right? Adult life and the older age group. What we find, and this has not been completely proven, but what we find, and this is just pure histology, that patients that have lower levels of carotenoids in their brain have a tendency to Alzheimer's, dementia, kind of diseases. A recent study done by Harvard showed that it is incredibly intricately associated. The reason I'm not going too deep into that area is more research is needed to actually fill. Just because it's associated doesn't mean it's causation, right? And so we want to make sure, we want to be careful in describing association versus causation, but our brain changes as we grow older. And adults that actually enhance the levels of carotenoids, older adults, 75 plus years of age, older adults that enhance the levels of carotenoids in their body can actually perform better on executive functions and actually solving puzzles, etc. So what that tells you is that this is, again, we don't have to accept old age sitting down. We can actually do something about it. And nutrition and nutritional supplements might be one of the ways to target that issue.
So we all should be eating more carotenoid. You make me want to go take a handful right now. Some lutein or zeaxanthin.
I'm looking around while you're talking.
Can I put it in my coffee?
I have a carbonated water, which is probably like depleting my carotenoids.
Well, we should actually make that carbonated water with some carotenoids and a little of omega. So the fish oil along with carotenoid, very tasty beverage, I think.
Have we just created a new business during this? I'm really excited. We'll talk about that in production after the call. Okay. I
think I was just to reiterate the pediatric and the TBI population that, post-traumatic brain injury that are really, I think, an untapped market for us as ODs to look into. So
I love that.
And don't forget, AMD disease pathogenesis starts at childhood. It doesn't start, you hit 60, you just become 60, let's click the
everything
clock
falls apart.
AMD. It's not like that. It's all going on throughout your life. So if you are taking care of yourself or your children in younger age, makes a whole bunch of difference towards the older age. Although people will argue 60 is not older these days.
Well, if cataract degenesis starts, somewhere around the age of 11, why not macular degeneration? I can totally I totally can grasp that. That's really cool. I want to cycle that back to something Julie said, another quote of Julie's: what's healthy for the macula is healthy for the system. And I want to roll that into a really interesting topic that I saw surface on ODs on Facebook a few weeks ago. Somebody brought up the product, and wait to hear the whole question, the product New Skin. And they have a device that a lot of ODs have in their practices that supposedly reads their vitamin levels by holding this, I guess it's an infrared device up to their skin and gives them a grade. I'm sure you guys are aware of this. Now, this is one of those companies, I believe they're a multi-level marketing company that also sells vitamins to, if you have a poor score, to up your score. I've been engaged in conversations with people that said, well, why do you need to buy those vitamins? Wouldn't just increasing your general nutrition and or taking good, well-respected vitamin brands bring that score up also? And I've always said yes. Tell us a little bit about the device, if you know about it. If not, special products that promise to do certain things, and how people might be able to get around using those.
Whew, that's a loaded question, and I don't want New Skin folks either sending me Christmas presents or actually throwing eggs at my house. So jokes apart. All right, so I'll be careful.
Nothing about the company itself, just
nothing about the company itself.
Yeah,
talking
exactly.
Scientifically. Okay, so I will talk about the machine. I'll talk about the correlation of scores and etc. And so we'll deal with all the science aspects, and then I'll come to the last one, which is very tricky to talk about: is special supplements, do they do special things? Right? Those are a three-part question.
Good.
So let's take the okay. Let me ask you this question. Say, Alan, I want to measure your height. What's the most direct way to measure your height?
For me, I'm really short, so a millimeter rule.
Okay, so you get so you actually get a guy to stand against the wall. You put a mark. You can take a meter rule and measure the person's height. That's the most direct way, right? Okay. Now let's say I say that I don't want to do it that way. I want to actually keep you next to Eiffel Tower, and then actually I know the height of the Eiffel Tower, and then I will correlate and find out the height of Alan Glazier. Would that work? Yeah, it could.
Right.
But would it be accurate? Would it be accurate is the next question. And the answer is maybe, may not be. So if you're interested in the eye, right, and if you can measure the carotenoid levels or the pigment levels in your eye directly, why would you want to go through the skin? Correct?
Right.
Because when they come in for an eye exam to an OD just doesn't look at the yellow spot and say, oh, you've got a great looking yellow spot. Although as Indians, I have a red spot on our foreheads, right? So you look at a great looking yellow spot is not the only thing, right? You look at the retina, you look at the blood vessels, you might find hypertension in that patient, you might find something else in that patient, which that person has no idea. So the eye exam, although the word collateral damage is often used, collateral benefit, quoting a Julie's word again, collateral benefits of an eye exam are so many, right? So measuring directly would be the way to go. So my roundabout answer is saying the skin is an indirect measure, and the skin levels don't correlate necessarily very well with your retina levels. Now, I can't take a brain biopsy on a patient, right? But I can do an eye exam, measure the eye levels, and that's where correlation is a fair adjustment, because brain biopsies is not possible to do. Just because something gets in your bloodstream and your skin doesn't mean it crosses the blood-retinal barrier or the blood-brain barrier. Okay, those are terms that we actually know about as optometrists. So the blood-retinal barrier actually selectively only allows two naturally available. So if you say that, Julie is taking her diet and food, two naturally available carotenoids get to your eye. And a third carotenoid, which can be artificially given, like the mesozeaxanthin, can also reach the retina. But two natural carotenoids make it to the eye. You have 750 of that in nature, 20 of that in the bloodstream, and only two that get naturally in the eye, right? So one can say that the skin levels are not going to be a direct level measurement of your retinal levels. So I hope I answered the question that I like a more direct measurement. Now you go into saying, can you do this with your diet? Absolutely. A good diet is a must and foundation. And if you eat your fruits and veggies and regular proper cooking, etc., you can get a decent amount of these nutritional supplements into your eye, body, and brain, right? So that's possible. However, most of us are not that careful in our diet and cooking stuff. Here's one, for example. Here's a myth to burst. Most people think fruits and veggies are best eaten raw. Probably the case for the majority of fruits and veggies. But let's take a kale, for example, or spinach, for example. These don't absorb well in the body if you eat them raw. You want to eat them a little bit cooked with a decent amount of fat in it, because it releases from the matrix of the food substance. Okay, so it's the way you cook, how you cook, etc., and it gets in there. So now it gets to the third point, which is the supplement. If you look at the supplement and you actually say, what is so special about that concoction that makes us absorb better? And there is a lot of trade secrets that most of these companies keep quiet, but there are some that actually come out in research arena. For example, making the molecule size smaller, enhances absorption. Taking the vitamin with certain omega oils may enhance its absorption. Of course, it enhances omega's absorption, which has its own benefits, but omega will allow for better absorption of carotenoids. So can there be special supplements that do special things? The answer is possibly. But can you, for example, not buy an individual supplement that a person's trying to push and then do your own theory and own homework and find another supplement that does that? The answer is absolutely. And as doctors, you could go to your optometrist's office and get your pigment level measured in your retina to see if it has increased or not. Because last thing you want is flushing down your money somewhere else, right? So you want to make sure that these are being absorbed. So there are checks and balances that could be put in place. I'm hoping I spoke very politically accurate, because I didn't want to misrepresent any technology in this fashion.
I think you did a great job with that. I think it was fair and balanced, and that's what we were looking for here. No interest in harming any company out there, but I do have an interest in delivering accurate information to doctors who are purchasing these things thinking that the claims they're making are accurate when they may be close to accurate, but not quite accurate. So that's great. That's great to know. Julie, do you have anything to add to that?
I do want to add that I don't recommend supplements in my practice. I prescribe them, and the ones that I prescribe have been vetted. And so that I know that I'm giving my patients something that has been shown to be efficacious for what I am prescribing it for. And again, so many of the things that I prescribe have so many different benefits to just not working on one system in the body. And we're in our profession to help people, but we also have to pay our receptionists and our techs and our opticians. And so there's a monetary value as well for prescribing and having those nutraceuticals either prescribed in our office or either in our office, provided in our office. So, again, I never recommend, I prescribe, and I prescribe things that I know through my own research and through studies on PubMed that have shown to be efficacious. So it's important. So there's so much out there, and patients are willing to spend the money, on things. They'll go into a health food store and spend money on things that may not be the right things, and they may be wasting their money. So it's important for us to tell them what we recommend as professionals. And that's what the OWNS, that's one of our missions is to help, our profession become more educated as far as what is efficacious, what has been shown to have clinical benefit, why are we doing this? How can we help our patients?
That's great. I love how you worked verbiage into the business and medical side of this. We really, anything we're recommending, we're prescribing. Mm-hmm. And the words that we choose to use influence people's decisions to buy. So I'm 100% with you there.
I have to admit, when actually she said that she doesn't she doesn't recommend vitamins, my jaw almost dropped at the floor. No, Julie, you really do that, don't you? And then she went on to say prescribe, which is of course the right, correct terminology that we should use. The other thing, here's a fun fact for you, Alan. In the military, if you told them to wear sunglasses, they don't like it because it shows weakness. But if you told them eye protective gear, they're okay with that. So, using the right terminology is very crucial in patients doing the right thing.
Right. And
Absolutely.
We're not going to have a news flash. The president of the OWNS is not recommending nutraceuticals today, right?
They're prescribing them. So.
Prescribing
them. There you go. Good catch. So let's go back to talking about the Ocular Wellness and Nutrition Society. It sounds like there's so much information, and just with you two running the organization, I'm sure the people you're working alongside of have a tremendous, like probably hundreds and hundreds of years of scientific knowledge to help people learn. What are some of the things of value that our viewers can get out of joining the OWNS? Julie.
Oh, do you want me to? We do a weekly blog. Since May of 2020, we've provided our members with 10 hours of free CE. After our March CE, that will be 12 hours of free CE for our members. We have a new website where we have a collaborative community of virtual, doctors who are all interested in ocular nutrition. We have 2 conferences every year. We have meetings in person. This is a huge deal. We just have developed an affiliation, thanks to Pinakan, and largely with the journal Nutrients, which is one of the preeminent journals for nutrition science. And to be affiliated with that is a huge deal for us and for optometry. Pinakan, I'm gonna let you jump in here now as well.
Oh, thank you for the plug, Julie. So we have, we also, so she said everything perfect about the CE, about the meetings, annual meetings. I also want to say that we have an annual publication on nutrition updates that actually is published each year. And 2020 was an odd year, but 2021, things should get back to more normal. And so there's an annual supplement on updates in nutrition and nutritional research, which is basically a summary of the hot topics that people want to know about and what's the research around which they don't necessarily have time to go and read the index journal articles. So we try to bring that to our group. And this is a benefit to the entire country, not just to our OWNS members, but the OWNS members should be proud that they're part of the organization that does this for the optometry and the ophthalmology community.
I'm sorry, Alan, I do want to mention one other huge benefit. OWNS has partnered with a master's program in human nutrition and functional medicine to allow ODs at a non-matriculation basis to gain the nutrition hours needed to become a certified nutrition specialist. Certified nutrition specialists are the most prestigious nutrition specialization recognized by Medicare and Medicaid across the country. But if you become a CNS, it will allow ODs to monetize nutrition consults in their practice. So it's another layer of expanding your scope. And through OWNS, if you're a member, you can, go and partner and take these classes for a reduced fee on a non-matriculation basis, so you can become a CNS. Because we just, as in medical schools as well, there's just not enough nutrition classes, enough biochemistry. And so, CNSs, a lot of CNSs are MDs. A lot of them are now ODs. Some RDs are now becoming CNSs, but it is the most recognized by insurance companies, by the government nutrition certification. That's a non-RD nutrition certification.
That's very interesting. Another revenue stream. As well as, a way to up your game clinically and stand out amongst your competitors who may not have as much knowledge or a certification like that. Fantastic.
There's one more thing.
Yeah.
One more. Just when you say it's done, we'll say there's one more thing, but
pull me back in.
The one more thing is that we also have an active fellowship process. So the Fellow of Ocular Wellness Nutrition Society is one way to actually step in the process where you actually, just like Fellow of American Academy of Optometry, that we all are so proud about, Fellow of Ocular Wellness Nutrition Society gets you to start the process, which could eventually build to become your certified nutrition specialist, CNS degree as well. So that's one more thing that I had to tell you.
Thank you. That's really important. And how do people find out more? Where do they go? What is the website and your other social handles they may want to connect with?
So the website is ocularnutritionsociety.org. And we also have a Facebook group. There's 2 different ones. There's one for members and then there's a general one. And one of our board members maintains that for us. But if you go to the ocularnutritionsociety.org, you can sign up, become a member, and join the wellness movement. And again, with the NIH's new initiative in nutrition research, this is going to be huge for us. And I think it's time for optometry to kind of jump more on the bandwagon with this, because this is the future.
I believe so. It's really important. I'm going to go after when we get off. I'm going to go and eat more leafy greens. I'm going to probably chomp on some zebrafish for glaucoma. I hear it might be good for glaucoma, right? Dr. Davey has done a few papers on zebrafish eyes, which we'll talk about some other time. But this has been fascinating, and I've learned so much, and I think that our viewers really benefit by checking out the OWNS online and some upcoming conferences, which I can't believe I'm saying that, upcoming conferences. We do have that in our not too distant future. So I look forward to connecting with you there as well. So thank you both for being here today, and thanks for sharing that, just a tiny sliver of your vast wealth of knowledge on the topic of ocular nutrition. And it would mean a lot to me if I could get you, before we close this talk, to commit to come back and talk more at some time.
We would love to. Alan, thank you so much for all you do for optometry and for having us on. We really appreciate it.
It's kind of you to say, Julie. Thank you.
Absolutely, Alan. On the record, I agree to come back and talk about the fish research, human research, and the animal research, etc.
So don't start eating zebrafish yet. Wait till you.
No, zebrafish wouldn't be the way to go. For omegas.
Great. All right, guys. Well, listen, thank you again. And I really appreciate you and what you do for the profession as well. And we'll talk again soon.
Thank you.
Hello and welcome to Fluorescene News. I'm your host, Dr. Alan Glazier. In Anterior Segment news, Tarsus Pharmaceuticals announced data from its Demodex blepharitis clinical program presented at ARVO. Tarsus's lead product candidate, TP-03, is a topical ophthalmic formulation of lotilaner, a well-characterized antiparasitic agent designed to target and eradicate Demodex mites, and is currently being evaluated in the pivotal Phase 2b/3 Saturn 1 trial. Tarsus presented the complete findings of the Europa study, a prospective randomized vehicle-controlled Phase 2b trial that evaluated the safety and efficacy of twice-daily TP-03 topical lotilaner ophthalmic solution 0.25% in adult patients with Demodex blepharitis. In post-hoc analyses, 93% of patients treated with TP-03 had a clinically meaningful outcome of 10 or fewer lashes with collarettes by day 42. Additional post-hoc analyses shows that 87% of patients treated with TP-03 had mite density reduced by 50% or more by day 14. There were no serious adverse events and no discontinuations due to adverse events. In diabetes news, Adverum, a company conducting studies on an experimental gene therapy for the treatment of diabetic macular edema, announced a clinical update regarding one of the pipeline candidates, ADVM-022. The company announced one patient treated with ADVM-022 during the clinical trial developed hypotony with panuveitis and loss of vision in the treated eye. Following that discovery, Adverum said that in the interest of patient safety, it had decided to immediately unmask the Infinity Phase 2 study. The move would help it better understand the adverse event and to help identify and manage any similar potential risk to other patients in the trial. In ocular cancer news, Biosciences announced the presentation of supportive preclinical data in multiple tumor models of choroidal metastases and in choroidal melanoma using suprachoroidal administration. New preclinical data demonstrates the potential of AU-011 for the treatment of choroidal metastases from breast and lung cancer, the most common causes of metastases in the choroid. In vivo, a single systemic administration of AU-11 in a syngeneic breast cancer mouse model demonstrated potent cytotoxic activity with significant reduction of tumor growth. These results suggested that AU-11 can bind to and kill tumor cells derived from the most common cancer types known to metastasize to the choroid, and supports further development of AU-11 as a vision-preserving therapy for the treatment of choroidal metastases. In AMD news, a study has found that patients who had uveitis or scleritis were more likely to develop age-related macular degeneration. This finding supports current evidence that AMD develops in the presence of abnormal inflammation of the eye. The study was designed to compare the risk of AMD in RA patients on tumor necrosis factor alpha inhibitors to rheumatoid arthritis patients on methotrexate, the first-line therapy for rheumatoid arthritis. It was performed on data from 2010 to 2015. Researchers found that the sample of patients with RA, immune modulation via TNF-alpha inhibition, did not change the hazard of developing AMD. However, there was an increased hazard for developing AMD in patients with uveitis or scleritis. These findings suggest that an aberrant immune response is implicated in AMD, though therapeutic targets of these pathways remain elusive. In ocular allergy news, a study assessed the post-acute activity and clinical utility of Reproxalap, a novel aldehyde species, RASP inhibitors, versus vehicle in patients with seasonal allergic conjunctivitis. In the Alleviate study, a double-masked randomized phase 3 trial, investigators found that Reproxalap was effective at reducing ocular itching in patients with allergic conjunctivitis. Alleviate represents one of the first allergic conjunctivitis phase 3 trials of a novel mechanism of action in decades. In glaucoma news, new research out of the University of Wisconsin-Madison identified an inverse reaction between macular pigment levels and open-angle glaucoma in a 15-year follow-up cohort of older women participating in the Carotenoids and Age-Related Eye Disease Study, or KREDS-2. The KREDS-2 study was the first to identify an inverse association between macular pigment optical density and manifest primary open-angle glaucoma in a longitudinal cohort for 630 older women. Further studies are warranted to confirm whether low macular pigment levels may be a novel, modifiable glaucoma risk factor and may support the development of low-cost dietary interventions for glaucoma prevention, such as dietary intake of carotenoids, including lutein and zeaxanthine. In spaceflight medicine news, the microgravity environment created by flying through space causes a range of physiological problems, we should say. One problem is damage to the visual system, which can lead to a disease called spaceflight-associated neuro-ocular syndrome, or SANS. Until recently, the syndrome had only been studied in astronauts who had spent 4 to 6 months in space, with little known about long-term effects. This study involved observing 2 crew members in low Earth orbit aboard the International Space Station, ISS, on a year-long mission. The study included taking photos of the ocular structures in both astronauts before, during, and after their time on the ISS. Those images were then used to measure things like thickness of the retina and length of the eyeball, as well as the length and depth of the anterior chamber. Measurements from the 2 men were compared against those from 11 crew members on 6-month missions. Results showed no major changes in most structures, including eyeball length and chamber size, but there were a few differences. After a year, both astronauts had developed swelling of the optic nerve. The swelling got progressively worse over time. One astronaut also developed folds in the choroid and the sclera. The study suggests that optic disc edema and choroidal folding contribute to spaceflight-associated neuro-ocular syndrome, whose symptoms include headaches and visual impairment, such as hyperopia. And that's it for the Fluorescene news. Enjoy the rest of the show.
So I am here today with an esteemed colleague, Dr. Paul Chous. Paul received his undergraduate education at Brown University and the University of California, Irvine, where he was elected Phi Beta Kappa in 1985. He received his master's degree in 1986 and his doctorate of optometry in 1991, both with the highest honors from the University of California, Berkeley. Dr. Chous has practiced optometry with a special emphasis on diabetic eye disease and diabetes education for 20 years in the state of Washington, winning the American Diabetes Association's Distinguished Public Service Award. So welcome, Dr. Chous.
Thank you very much, Dr. Glazier. It's a pleasure. Thanks for inviting me. I appreciate it. The only correction I'll make is I got to say it's 30 years now I've been doing that. I'm an old man now. You know, life goes by pretty quickly, doesn't it?
Yeah, you've only got 2 on me. I feel sorry for myself quite often. Yes, it's how you act, right? It's all in how you act and how you feel. As you know, that's a good segue into your expertise in diabetes. Why don't you give our viewers your background and your specialty and how you apply it to optometry, and just talk about you a little while.
Sure. So I got type 1 diabetes when I was 5 years old. It was right before Easter, I remember. And, didn't pay much attention to it growing up. And in my senior year in college, I was told by my big brother, who was a fourth-year optometry student at the Southern California College of Optometry. I know it's got a different name now, Marshall Ketchum University, I think. And he dragged me in, dilated my eyes, and said, I see some changes back here that worry me. And I kind of blew him off, right? He's my big brother. What does he know? And he kind of was forceful about it and dragged me in to see a retina specialist. And I had proliferative retinopathy and underwent a bunch of laser photocoagulation and had a vitreous hemorrhage. So for about 3 to 6 months, depending on which eye, I was kind of incapacitated, was having friends hold my arm and kind of walk me around. I was in my master's program at Berkeley in political science, of all things, and couldn't really function all that well. And then when I got into practice, the person that employed me knew that I had diabetes and was asking all of his patients with diabetes to come and see me. So I kind of realized, because there was a great interest in this, patients wanted more counsel about how to better manage their disease. And I realized there was perhaps a niche for me. And when I broke away from that practice, my own endocrinologist actually asked me to open up nearby his office, which I did. And he was wonderful and sent me, 10, 15 new patients every week for about 15 years until he retired. And so my emphasis is really on helping my patients not develop diabetes. That's the first thing. You won't go blind from it if you don't develop it. And secondly, once they have been diagnosed, how to manage it most effectively so they don't end up with complications in the eyes and elsewhere. So that's kind of been my last 20 years, is really focused on diabetes and doing a lot of talking and writing about it. And it's been a huge practice builder for me. And I got, I have endocrinologists and cardiologists and a few PCPs that are referring to me kind of as their go-to person, educating their patients about diabetes and taking care of their eyes.
Wow. So you're very prolific, over 100 articles. Is that right? On diabetes? Is there an emphasis within diabetes, or are you all over the place as far as optometry is concerned?
No, I'm sorry. I didn't really talk about the direct relevance to optometry. I'm all over the place. I talk, I speak, write about diabetic eye disease, but also systemic diabetes. I think our patients have a real thirst for more information about diabetes. And, endocrinology or even PCPs don't really have the time to spend educating patients, And the data says only about 5% of patients, when they're diagnosed, get any formal diabetes education. And so that's kind of my mantra to my colleagues is, we can really fill a huge gap in terms of patient education. And I write it's a quarterly column for Optometry Times that's devoted specifically to topics around diabetes. And it ranges from, diabetic eye disease and new studies, but also out to systemic therapies, new drugs that are cardioprotective and renoprotective and the like. I'm all over the place. Is the best answer.
Well, it's all over the place within a specialty, so I'm sure it adds value. One thing you learn in one area adds value somewhere else. But what I'm not quite clear on, if you've been able to add value, is how you've been able to combine your master's in public policy, was it, with your doctorate?
It was political science.
Oh, political science. Have you been able to, in some area within your professional life, have combined those two in any way?
I love the question. No one's ever really asked me that before. I've been to the state legislature advocating for expansion of scope for optometry in the state of Washington. I've done that, 20 years ago now. But the one thing that I did carry over, my favorite professor in political science, the guy that kind of told me I should teach it, get a PhD. And I got depressed getting a PhD in poli-sci. It's not a really uplifting topic, and you're kind of alienated. Optometry school was wonderful because there was camaraderie, with classmates, and now with my colleagues. but I wrote an article based on a book written by my favorite professor in poli-sci called Those Who Aren't What We Call Them. And it was all about adolescents actually being adults and being treated as children still. So he said, all other species are adults when they can rear children, when they can have children. And so we have created this artificial category. And so his argument was we should treat people more fairly, not treat them as things that they aren't. So I've written a couple of papers on not actually calling our patients diabetics. That was my one political science takeover into optometry. And I think, patients generally don't want to be known as their disease, right? Right. The word is it's existentially diminutive, right? Diminishes the totality of their humanity. And so I try not to call people myopes or keratoconics or cones or diabetics, because we don't call people macular degenerates or, epileptics, although sometimes they are, it sounds silly, but honest to God, I've had patients, we've had this discussion, and they've broken down in tears sitting in my exam chair when they said, you're the first provider I've seen that understands diabetes is not the totality of who I am. And I think that's an important message we can all bring to our patients.
It is. And hopefully somebody will take that name macular degenerates and apply it to their rock band. I love it.
Right.
They teach you, it's not the cone in room 2 or the cataract in room 3. I hear what you're saying. I think that's a really important message.
Yeah, I sang in a band in optometry school. We were called Drusen, so that was kind of fun. We reformed as virtually erect images in our 4th year. That was the most fun I've ever had, actually.
Yikes, you do a lot with that name. Hilarious. No, so you're involved in clinical research also. Can you tell our viewers what you're working on now or have worked on?
Yeah, sure. So I was not involved in research really heretofore. And about 10 years ago, I started working on a project with Zeavision, which is now, I Promise. And so I was the PI for a study called the Diabetes Visual Function Supplement Study. And it was based on the premise that perhaps an AREDS, an AREDS type multi-component supplement might benefit people with diabetes. There's a lot of evidence out there that visual function gets mucked up in diabetes long before patients have retinopathy. And so I was the PI for the study. We got published in the British Journal of Ophthalmology. It was Jeff Gerson, myself, Stu Richer that worked on the paper. I wrote it. It was a lot of work. I realized how hard research is. But basically, we were able to show with this formula that kind of we all collaborated on that we could improve patients' visual function. Amazingly, the thing that blew me away was that it improved people's C-reactive protein dramatically. And these are all patients with early non-proliferative diabetic retinopathy. And people's neuropathy symptoms, those who had it, actually got better. So that's kind of the one research I'm most proud of. And we're doing follow-up studies now. I'm kind of helping oversee them, but I'm not the PI. Using the same formula we tested in humans, and then we did it in an animal model. We're doing a study in diabetic macular edema, one using ERG measurements, and another study looking at optometrists as diabetes educators and adding in this formula to see if patients do better on things like OCTA. So I'm excited. The thing that, spurred me to do this just was a lot of patients are told, here's what you should do. Come in every year for a dilated eye exam, try to take care of your diabetes, and we'll just wait and see what happens, right? Watch you every year. When things go to hell, we'll laser your eyes or start giving you injections. And so I was interested in maybe something that is more preventive that could be applied. And I think that we've hit upon something, and, research is ongoing, but that's kind of my passion, is to keep patients from needing expensive and destructive photocoagulation, but also really expensive anti-VEGF therapy.
Yeah, that was amazing in our career to see something come around like anti-VEGF, which totally reduced the morbidity of some of these conditions just so dramatically you couldn't even imagine it. it was twice in our career. We had LASIK for refractive error and VEGF, and I put them on a similar plane, even though, they're very different disease conditions, but fantastic. Is the paradigm for treatment for diabetic eye disease since VEGF changing? And if so, what direction is it taking? What can we look forward to seeing in the near future that is more than incrementally different?
Yeah, I mean, that's a great question. So, the evidence is saying that we should be treating patients earlier than we would have before with less severe diabetic retinopathy using anti-VEGF therapy. So the study that, there's multiple studies actually with multiple anti-VEGF agents that suggest this, but you can take somebody with severe non-proliferative disease or even before that and use anti-VEGF therapy to prevent them from progressing on to vision-threatening diabetic retinopathy or, iris neovascularization. And so I think that is a paradigm shift. We think about injecting patients when they get DME, but, the anti-VEGF agents now, the approved ones, are approved for treating any degree of diabetic retinopathy. Most patients, of course, aren't going to get injections if they've got mild disease. But when patients get past kind of the moderate stage, what's called moderately severe, there's pretty striking evidence now that those patients can be, this is my new metaphor, I've ripped it off from colleagues, pull patients back from the edge of the cliff. I saw a patient on Friday who was referred to me by his endocrinologist. He had seen an ophthalmologist who told him, you've got pretty bad retinopathy and I'm recommending anti-VEGF to you. The patient didn't want to hear it and he left, and it was 6 months later he was referred to me kind of as a second opinion, quote unquote, from ophthalmology. And we had a long talk and I tried to convince him, this is something you really need to have addressed, and nothing worked. I showed him photos. I actually use an artificial intelligence program in my office that grades the retinopathy based on photos. So, that showed him that it was severe, but the final straw that got him to say, okay, I'm going to go in and get treated, is I told him, it's like literally you're standing at the edge of a cliff and you can take a step forward and fall off. You're going to lose your vision. You have great vision until the day you suddenly don't. And the other option is we can pull you back from the edge of the cliff. And that really resonated with the patient. I'm not a huge fan of using metaphors, maybe because I'm a doctor, right? When specialists I see use metaphors, about why my apnea is like a car that's stuck in a ditch, I'm not really, that doesn't excite me. I want to hear the science. But for patients that aren't medically educated, sometimes effective metaphors are really a good way to go. And this patient, I talked to him yesterday. He went in, then he got his first anti-VEGF injection yesterday, which was Monday. And so I think, I don't know where I'm going with all this, but just essentially, I think that's one of the breakthroughs, is that earlier use of some of these agents. And the other thing I'll just quickly say, there's new agents on the horizon that are going to be more effective and they last longer. Because that's the question that I get all the time from ODs and from primary care docs, but also from patients is, do I have to keep getting injections, for the rest of my life? You're treating my DME or even my diabetic retinopathy. How long does this have to go on? And the answer is we don't really know yet, right? The data, we don't have 10-year data. We have like 2-year data coming up on 3 years. And so I think as agents are more effective and can be administered less frequently, that becomes more and more appealing. And I think topical anti-VEGF therapy, I'm excited about the possibilities there, even though nothing has been brought to market yet.
Yeah, the penetration is the issue. They're always getting it past the corneal barrier and without causing problems. I'm aware of that. That's really fascinating. Also, that they're taking it to the next level with those medicines. Like, they're just, to me, 95% success rate is I believe that's what it was last time I read an article. It was amazing. So you covered a few areas I was going to ask questions on. It was a great segue into I wanted to ask into the next. So it was a great segue into the next area, which was to talk about a time. If you could tell us about a time when it sounds like you work really well with the medical community. You're talking about working with GPs and endocrinologists. And was there a time where it wasn't so easy for an optometrist where you are to get the respect of those professionals? And tell us about how you built your practice up so that they willingly refer to you.
That's a great question. And yes, and still to this day, there are PCPs that don't want an optometrist to see their patients. So my strategy has been, I'll work with the people, with the providers that want to work with me, that are smart and realize I know a lot about diabetes. I can actually help them do a better job managing their patients. So the strategy really revolved around my own endocrinologist asking me to open up a practice near him, which is what I did. And then he said nice things about me to his colleagues, and that helped. But my other strategy was I either went into the offices of PCPs or sent notes inviting them to come take a look at my practice, to see OCT, to see, wide field retinal imaging and the like. And slowly over time, I've built up a cadre of general practice, primary care providers. I have a ton of ARNPs that send to me, and I've spoken at some of their meetings, and that's really good because then they know what you're talking about. But I think just being good at what you do, sending timely communication, letting them know that you're on their side and you want to help them do a better job managing their patients. Some physicians are more than happy to work with an optometrist that knows what she or he is doing.
Don't forget fruit and gift baskets. That's very important. I found that very important. When I was looking for medical referrals, it was always fruit and gift baskets. Nothing else worked. I could send them letters, detailed letters through the nose. But once they got some chocolate, it seemed like I started to get the patients in the door.
Isn't that interesting? Yes, one of the retina specialists I referred to for a long time, used to send me a bottle of port and dark chocolate. And that, I swore to my wife, who's my practice partner, we're going to send everybody to this retina specialist. Look at this great gift he sends us every year.
Right. That's so funny. So can you in summing up that area, can you give our viewers some advice on building relationships with GPs and endocrinologists and between them and the OD, and also out of all the specialists that might refer diabetics, who do you think is the most important to build those relationships with?
Yeah, so I focus on primary care docs, nurse practitioners that see a lot of patients with diabetes. If you can establish a good relationship with an endocrinologist or his nurse practitioner, because typically they work, with other healthcare personnel, that goes a long way. And I'm kind of embarrassed to say it, but for a while, what I was doing, I was making appointments as a patient myself to go see various subspecialists, a nephrologist, a pulmonologist, a sleep medicine specialist, endocrinologist. And then in the course of the conversation, what do? You're an optometrist. And I would tell them, yeah, I specialize in diabetes. I wrote a book. It was a long time ago now, almost 20 years, but, I'll bring a copy of the book in with me and hand that to the physician. And that has actually resulted in a lot of referrals. And amazingly, my biggest referral source, other than family practice docs lately, has been cardiologists. And it's one specific cardiology group because I talked to the patients about these new medicines for type 2 diabetes that have been shown to dramatically cut the likelihood of an MI, a stroke, or dying from one of those. And so the one cardiologist actually called the office. He said, let me talk to Dr. Chous. And he said, you're the only eye doctor I've ever seen who's talking to patients about these drugs that are cardioprotective. Send me 100 of your cards. And so, that if you can find one person who believes in you, that can grow a practice.
That's wonderful. I would have never thought about cardiology. Fantastic. So, COVID has been for most of us, it's been a situation where patients haven't been able to get their standard refractive care. They haven't been able to come in for their general eye exams, their contact lenses, their glasses. And we see a trickle of patients with pathologies, at least in many of the states. Some states see more medical than others. Where you are, you have a practice where you've really specialized in diabetes and patients who have much more serious care. What have you seen during COVID in terms of the lack of care or not being able to come in for care, or maybe how it's impacted your practice recently?
Another great question. Yeah. So a couple of observations. Patients are heavier than they were the last time I saw them. They're gaining weight, right? Whatever it is, the COVID-15 or COVID-20.
That's scary.
Patients' hemoglobin A1Cs are higher than they were, or patients haven't had them done in a while. My own endocrinologist has done only virtual visits for the last, 9 months or so. when it's really important is when patients have disease, eye disease that needs treatment, right? So I've talked to a bunch of retina specialists that said they've had patients coming in, missed anti-VEGF therapy, and now, they've lost a ton of vision. So I'm trying, in my patients that are undergoing therapy, to send them, I have a text system for recall, texting patients to remind them, you got to follow up because we don't want you to lose vision. Now, on the other end, we know diabetes is a risk factor for bad outcomes if you get COVID. You're not more likely to or end up on a ventilator, 5 to 10 times more likely. Wow. So this is another message for patients. Studies out of Europe, and this is, 100,000 patients, say that if you're entering blood glucose when you're admitted to the hospitals above about 190, your risk of dying is about 7-fold higher. The risk of permanent cardiac damage is 10-fold higher. So more than any other time, it's imperative that patients with diabetes try to get good blood glucose control. And it's hard, right? Because we all stress eat. I do too. My A1C is worse. I've gained 20 pounds. I'm not happy with myself. My view now is I just got to get through this. Hopefully we all get vaccinated and we can start tamping this thing down. But I'm not sure. And when I talk to colleagues, I don't know, what you hear, Alan, but, I think there's still a great deal of uncertainty here about when life returns to normal.
Yeah, especially in the diabetics. One of the thoughts I had was I'm looking at some of the concerns. They're worried about chronic conditions that occur as a result of having COVID in both the symptomatic and the asymptomatic. And being a blood vessel disease, this COVID seems to appear to impact the small blood vessels. Hello, diabetes. Do you see any problems down the road in excess for diabetics because of that combined effect, like the double punch to the blood vessels?
Potentially, yeah. So there are 2 studies now, one out of England and one out of Scotland, and they both found the same thing, which was that if you already had diabetic retinopathy, and it actually didn't matter how severe it was, if it was mild, if it was PDR, those patients were dramatically more likely to be put on a ventilator or to die. So I think the potentiality is there for, if you get infected with COVID, for it potentially affecting blood vessels. I haven't seen the data that proves that yet. But particularly for patients with pre-existing retinopathy, double mask, stay out of the, I got a message from the public health department yesterday that said, we're advising against, any kind of routine grocery shopping on any more frequently than every 3 days or longer. So it kind of got me thinking about, okay, I don't want to go to the grocery store anymore. When I do, I'm putting on everything I possibly can to keep the virus out of my system. But to your point about asymptomatic disease, I mean, that's the big wrench in the whole system, right? My sense is, and this is not a political issue, I don't think, but if we had all just stayed home for 2 months and not gone outside, I know that's impossible, but if we could have, probably the disease would have died in our homes. The virus would have worked its way out of the population. But we haven't really learned. I wrote a paper with a colleague from Berkeley, Greg Hom, who's an OD and master's in public health. We wrote about pandemic influenza and how it might affect optometry. We wrote this paper, I think it was 2005, and we had predictions in our paper then. Surge capacity, our ICUs won't be able to keep up. Look at the lessons of the 1918 flu pandemic, and it seems like we haven't learned all that much as a society in terms of how to prevent transmission, of a highly contagious disease. Just thank God, the R naught of this disease is not like it was for smallpox, right? We'd be looking at a much worse catastrophe than we already are, and it's bad.
We're going to get closer to wrapping up now. I like to let the viewers get to know you personally a little bit. Tell them about some of your hobbies or your interests or passions outside of optometry.
So first of all, you can see I'm a spaz. I'm a type A personality. So I married a really mellow wife, thank God. And the people I lecture with generally are mellow, so we kind of balance each other out. So the thing that I really love is playing guitar, and I'm not particularly good at it, but I'm trying to get better. I've got a son who's playing guitar now too, so I'm trying to get together and do some jam sessions with him. I like that a lot. I like reading all sorts of things, but I'm constantly have my nose in an article or 2 or 7 about diabetes in particular. So what I'm trying to do is become a go-to person, a resource within optometry, and can be a liaison to other, healthcare providers, because I want them to realize that we in optometry have a lot to offer that perhaps they didn't realize. Most primary, and I know I'm back into the eye care part of it, but that's what I do all the time is I'm reading articles constantly. I play guitar, I see patients, and I have a cat that likes to sit by the fireplace, and she's kind of my hypertensive therapy as I go pet her by the fireplace, and that's what calms me down.
Well, it's okay that the study and learning is your passion. And just because it bridges into the profession, that doesn't mean it's not a hobby, but it's also something that means something personally to you. That's great. And I'm a huge audiophile, so I appreciate the music and the guitars. I have a keyboard here, my guitar over there, and I use this studio for that as well. So we share that. Tell us about, you mentioned your family. Tell us about your family.
So my wife is Elizabeth. She's an optometrist. We met in optometry school. She's great. She is the anchor of our family. And I have two sons, one who's 20, one who's 6. They're both going to virtual school. One's in virtual college now. The other's in virtual school. And they are great kids. I never thought I wanted to have kids. And that's what you say until you have kids, right? And then you realize how wonderful it is. Costs a lot of money though, doesn't it? And there's a lot of extra stress. I used to have jet black hair, honest to God, about 10 years ago. And I'm thinning out and much grayer than I used to be. That's for sure.
Don't get me started on the hair thing. My God, don't expect any sympathy from this side of the camera. My God, that's awesome. Where does your son go to college?
So he's in a community college right now. And so he wants to be an engineer. He's not a good student. Like one of the smartest people I've met, and I'm not saying that just because I'm dad, but, I'm seeing this in my patients actually, that there's a lot of unmotivated kind of high school, early college students living with their parents who might be, physicians, lawyers. And, this generation in large measure seems to be less motivated perhaps than, my generation was. But I'm hoping, he's finally kind of found his groove and he wants to go into engineering. The other kid has no idea what he wants to do. And that I'm sympathetic to that because that was me. I was going to get a PhD in poli-sci until I realized what an alienating, kind of depressing life I was going to lead. And I have people from Berkeley that I went to graduate school with that got their PhDs, really smart people. And this one guy in particular, he's written 7 books on Hegel. Not expecting anybody to know a lot about Hegel.
He's a philosopher.
This guy philosopher, kind of a political philosopher. And this friend who has a PhD from Berkeley has like 4 different appointments at community colleges. And he teaches 2 days a week at Stanford and no benefits. He kind of like tries to piece together an income. So it's become increasingly difficult to become an academic, and whether that's a good thing or a bad thing, I don't know. But I'm glad that I was driving down the freeway in Los Angeles, and I had to make the decision to go back and get a PhD in poli-sci because I just got my master's, and or switch courses. My big brother was an OD, as I said earlier. He encouraged me because I wasn't sure to think about optometry because he really liked it, and that was the best move I ever made, was going into optometry.
Well, that's great to hear, and hopefully the viewers who are younger and maybe even students will take that to heart, and that'll make them feel better because the students are the pets are the beneficiaries of this pandemic. They're home all the time. The students are the ones who are suffering the most and having the hardest time. And I have children, a young college freshman, and I have a senior in high school, and very similar. One knows what he wants to do, one doesn't, but it'll all fall into place for them. Just have to give them the support and that they need and the resources to learn about what the options are out there. So that's great. Two boys.
For sure.
Me too. That's great. Well, listen, I really enjoyed this interview. I can't wait for people to the takeaways about diabetes and the updates, because this is a topic that it can be stale, but when you bring in an expert like yourself, you really added some life to it and updates for everybody. So thank you for that. And I'd love to have you back to talk more about it sometime in the future.
Be more than honored to. Thank you very much for inviting me to come and talk to you today, Alan. I really appreciate it.
My pleasure. My pleasure. Thank you so much.
everyone. It's Dr. Stephanie Wu with Wu University, and it's my pleasure to be here with you guys today. And our next question is another question that comes up all the time. And the question today is, how do I get staff trained with specialty lenses? Now, this is really, really, really important because when I first started in specialty lenses, I was the only one in the practice that knew how to do anything. So I had to do the entire thing. I had to do the patient intake. I had to do their case history. I had to do all of the equipment and testing and machines used to work the patient up for their consult. If they ended up wanting to proceed with the specialty lens fitting, I was the one that has to explain the contract, what's included in the pricing, all of that stuff. How does the billing work? Then I had to be involved with the fitting, the follow-up care, running all of the machines and pieces of equipment during those exams. And then lastly, I had to be involved with the billing. I had to learn all of the different codes that were appropriate to use. And that's great in the very beginning, but after time, it really eats up at some of that valuable doctor time. And so it was really, really important to get some of the staff trained to help me so that I wasn't taking care of the patient from the very beginning all the way till the very end. So the first piece of information or tip that I would have is get somebody trained that is going to help with insertion, removal, and lens care. Most all of you probably already have practices where you have a technician or an optician who is helping patients to learn how to fit soft contact lenses, to learn how to put them in, take them out, how to take care of them, that kind of thing. So that person is one of the best people to start training right away, because as a doctor, if you're spending an hour with a patient trying to train them how to put the lens in and take it out, that's just really eating into valuable doctor time. So for sure, start with getting a staff member who's already proficient in training contact lenses to learn how to train specialty lens patients. Now, the way I did it is I did everything myself. So I would start by having them watch a movie, an informative video that explains what scleral lenses are, how to insert them, how to remove them, how to inspect it to make sure that there's nothing wrong or defective with the lens, how to care for them, these types of things. So in that case, that is another free video that you can get from the Scleral Lens Society. It's right on their website. You can even probably find it on YouTube. But I always have my patients start with that movie. I think it's about 10 minutes long. So it's a really great overview of scleral lenses and kind of goes through the process before you actually start working with them. Next, you're going to have the patient practice. And they'll probably already have the scleral lenses in their eyes because you will have just done their dispense, checking everything, and now they're ready for their training. So what I did was I would perform the training, and I would have a staff member in there taking copious notes. You know, they were writing down everything, what I was saying, what kind of tools I was using, what kind of solutions were appropriate. So they were taking lots of notes. So we probably did that on 3 different patients. So I did the training still, and then the staff member would come in and then they would take a bunch of notes and observe. Well, then once they felt comfortable, then we switched roles. And then I was the observer, and then the staff member was doing all of the training. So I was watching them and observing, and then I was taking notes. And then after they were done, then I could provide them feedback. Of course, if there was anything that was obviously wrong or could be harmful to the patient, I would interject and just correct the staff member when they were doing the training. But other than that, I would just kind of sit back and observe. So once the staff member got comfortable, then I felt, after I had witnessed and observed a few of these, and I felt very comfortable that they were saying everything properly, they were giving the patient the correct instruction, then I let them free, and then I didn't have to be involved with that process anymore. So that's the very, very first thing I would recommend. If you are first starting to get into specialty lenses and you're having to do everything, the first person that you need to train is a staff member that's going to help with insertion, removal, and lens care. Now, if you are doing everything, or you have some extra time in between patients, or maybe you had a no-show, or maybe the staff can come in early, sometimes I would have the staff members practice on each other. So for the insertion and removal training, if I wanted to get another staff member trained, or I wanted to perfect the original technician's skills, I would have one of the other staff members come in and we would practice on them as if they were a patient. And so that was always really fun and a great way to use time if there's a no-show, so the staff aren't just sitting around. So I hope that was helpful, and super happy to answer any of your other questions. You can reach out to me anytime. My email is drwu@wuu.org. My website is wuu.org. And my Instagram and Facebook account is @DrStephanieWu. Please reach out to me to any questions, and your question may be featured on the next episode. Bye.